have a guest lecture chaired by Dr. Aarti Kannan ma'am, MD and Diploma in Diabetology, physician and diabetologist in Tuticorin. Ma'am, I'd like to request you onto the dais for chairing the session. The speakers can collect their gifts in the registration desk. Madhuwanthi ma'am, MBBS and FACP in USA, FRCP in Edinburgh. She is specialized physician in internal medicine, teaching hospital in Sri Lanka, invited speaker, who's abstract reviewer and a poster judge in several local and international conferences. She would be joining us online.
Good afternoon, ladies and gentlemen. Warm greetings from Sri Lanka. At the outset, let me thank Prof. Arul Raj for giving me an opportunity to speak to you all at this prestigious forum. My topic today is the role of alpha blockers in uncontrolled hypertension. I would like to share some beautiful sceneries from Sri Lanka, and I'm fortunate to wake up to these beautiful vistas every day. I have taken them from my home. Each sunrise and sunset will reveal unique mystic beauty of Sri Lanka, which is yet to unravel in most parts of the country. And same applies to the topic today, the role of alpha blockers in uncontrolled hypertension, which is yet to unravel. And there are studies which are done, which are for and against its use in uncontrolled hypertension. So without further ado, let me take you through to the roadmap. During the next 20 minutes or so, I'll first discuss about the definition and epidemiology of hypertension and move on to discuss the definition and epidemiology of uncontrolled and resistant hypertension. And I'll briefly touch on alpha blockers, what they are all about and how they act, and talk about indication of alpha blockers in hypertension, citing available studies as examples. So when you talk about hypertension, it's one of the leading preventable cause for premature morbidity and mortality worldwide. And it has an estimated prevalence of more than 25% in the adult population, and it accounts for about 13% of deaths. And it's one of the major risk factors for stroke, MI, heart failure, CKD, cognitive decline, PVD, as well as premature deaths. How do you classify hypertension? According to the International Society of Hypertension, the guidelines were released in 2020. Hypertension is defined as the clinic systolic blood pressure value more or equal to 140 millimeters of mercury and or diastolic blood pressure value more or equal to 90 millimeters of mercury following repeated examinations. And in this group, you can see there's grade 1 and grade 2 hypertension with isolated systolic hypertension. And there's another category called high normal blood pressure also. BP targets according to the ISH 2020 guidelines for less than 65 is less than 130/80. And if they are more than 65 years of age, the target would be less than 140/90. So what is the prevalence of uncontrolled hypertension? In UK, 30% of patients will have uncontrolled blood pressure. And according to a worldwide report in 2010, only 36.9% adults with hypertension were treated with antihypertensive medication. And 13.8% had their blood pressure under control. So it's an alarming figure. So globally, only 1 of every 7 people has their hypertension under control. And it's the case for many countries across the world. So what is the definition of resistant hypertension? The word resistant hypertension and uncontrolled blood pressure, most of them use interchangeably. The uncontrolled blood pressure can be due to resistant hypertension also. And you need to exclude the causes due to pseudoresistance and secondary causes such as pheochromocytoma. The failure to achieve goal blood pressure less than 140/90 or systolic blood pressure more than 160 millimeters of mercury in patients with isolated systolic hypertension, despite adherence to an appropriate 3-drug regime, including a diuretic, is called resistant hypertension. Now you have to have all three drugs prescribed in maximally tolerated doses, and the patient should adhere to this, and there should be an adequate and appropriate drug regime in place. So this is how you approach a patient with resistant hypertension in a schematic diagram. I'm not going to go into details of how to analyze this situation because it's beyond my talk. Now you need to exclude patients with pseudoresistance, of course. There are three main problems which require special attention. There can be patient-related problems, physician-related problems, or blood pressure technique-related problems. Examples are poor BP measurement techniques, white coat effect, non-adherence, failure to adhere to lifestyle modifications, drug-induced hypertension, and suboptimal choices in antihypertensive therapy. So you need to check on the lifestyle of these patients, whether the patient is on a low sodium diet and they are doing exercises, safe limit on alcohol, healthy diet, and are they adhering to prescribed therapy. And secondary causes for hypertension, such as pheochromocytoma, also need to be considered. So what is the epidemiology of resistant hypertension? And it affects around 10% of hypertensive individuals. But having said that, please remember it's difficult to actually assess the true resistant hypertension because most of the time they do have pseudoresistance. Approximately 50% of patients diagnosed with resistant hypertension have pseudoresistant rather than true resistant hypertension. So let us talk a little bit about the alpha blockers. They are used in the management of benign prostatic hyperplasia and pheochromocytoma. It was used in essential hypertension previously before the ALLHAT study. Depending on which receptor it blocks, alpha blockers fall into three different categories. Can be non-selective alpha blocker, alpha 1 and alpha 2, selective alpha 1 blocker, and selective alpha 2 blockers. Only non-selective alpha blocker and selective alpha 1 blockers are useful in the management of uncontrolled hypertension and related conditions. Alpha blockers produce their pharmacological effect through the alteration of the sympathetic nervous system. There are two types of alpha adrenals, alpha 1 and alpha 2. Most of these alpha 1 adrenergic receptors are located in the vascular smooth muscle, as the skin, sphincters of the GI system, kidney, and brain. They cause vasoconstriction when activated by catecholamines such as epinephrine and norepinephrine. The vasoconstriction causes an increase in both systemic arterial blood pressure and the peripheral resistance. And norepinephrine has a higher affinity for this receptor than epinephrine. Alpha 1 adrenergic receptors causes vasoconstriction when activated by catecholamines such as epinephrine and norepinephrine. Alpha 2 adrenergic receptors are located on the peripheral nerve endings and they can inhibit the release of norepinephrine when activated, which provide a feedback mechanism for norepinephrine to inhibit its release. Non-selective alpha blockers cause vasodilatation by blocking both alpha 1 and alpha 2 receptors. The blockage of alpha 2 receptors will increase the norepinephrine release and then it will reduce the force of the vasodilatation induced by the blockade of the alpha 1 receptors. Phenoxybenzamine and pentolamine are examples, and phenoxybenzamine is irreversible while the pentolamine is reversible. Action of these medications are best seen when there's increased sympathetic activity, such as the case during stress or when there is an increase in circulating catecholamines. Therefore, these are very useful with pheochromocytoma patients to manage the hypertensive crisis which might occur intraoperatively when you remove the pheochromocytoma. Selective alpha 1 blockers cause vasodilatation by preventing norepinephrine from activating the alpha 1 receptor, and it results in a lowering of blood pressure and allow alpha 1 blockers to be used for hypertension. It also causes relaxation of smooth muscle in the prostate. and it enables the urine to flow more freely, and it is useful for the management of benign prostatic hyperplasia. Selective alpha-1 blockers include alphozine, doxazine, terazosin, tamsulosin, and prazosin. These are FDA-approved medications to treat benign prostatic hyperplasia. Selective alpha-2 adrenergic antagonists inhibit negative feedback of norepinephrine, stimulating the sympathetic nervous system. However, these are very limited findings on significance of this mechanism of action on human medicine. So, it's very irrelevant to our patients. So, this is a summary of alpha blockers. The alpha blockers are actually having a lot of side effects. That's one of the reasons why we are not using it very commonly. That include hypertension, weakness, tachycardia, and tremulousness. And hypotension is due to the inhibition of alpha-1 receptors, which causes vascular smooth muscle relaxation and vasodilatation. The remaining adverse effects occur due to the increased release of norepinephrine when alpha-2 receptors become simultaneously antagonized. So the side effects profile of alpha blocker, tachycardia and tremulousness are less common with selective alpha-1 blocker, though it can cause first dose hypertension, syncope, dizziness, headache due to vasodilatation and vascular smooth muscle relaxation. Reflex tachycardia may occur as a result of sudden decrease in blood pressure. So the elderly are more prone. So therefore, there can be increase in the risk of falls. So patients are advised to take these medications, especially at night, to prevent these adverse effects. So let's move on to the controversies of alpha blockers in uncontrolled hypertension. The use of alpha blockers in uncontrolled hypertension is actually controversial. There are 188 published studies between 1966 and 2001 on cardiovascular randomized controlled trials related to the treatment of hypertension with the use of peripheral alpha-1 antagonists. Out of them, only ALLHAT has specifically assessed the differences in cardiovascular endpoints resulting from the control of hypertension. Actually, there are no case control cohort or other studies that analyze the impact of these agents on the cardiovascular endpoints. The doxazine arm of ALLHAT was stopped early because there was a doubling of incidence of congestive heart failure in this group when you compare to the low-dose clothalidone arm. With the publication of these trials, the role of peripheral alpha-1 antagonists in the treatment of hypertension has become controversial. According to the JNC 6 recommendations, peripheral alpha-1 antagonists are recommended not only as a second-line antihypertensive therapy after low-dose diuretics and beta blockers, their first-line agents are those, but for specific indications such as therapy in men with hypertension and prostatism. But they have recommended alpha blockers in patients with dyslipidemia, which was actually controversial, and I'm not going to go into details because it's beyond my topic. ISH 2020 recommendations are actually against alpha blockers. The newest guideline neither recommend the alpha-1 adrenergic antagonist as a first-line agent nor as an add-on therapy. And alpha blockers are not included in this stepwise approach of the treatment. So you can
An excellent talk about the role of alpha blockers in uncontrolled hypertension by Dr. Madhuwanthi from Sri Lanka. We thank her for an elaborate talk. As she has not joined us online, we do not have any discussion on this topic. We shall now move on to the next topic for the session. Next talk will be by Dr. Jyotirmay Paul, who will be joining us online.
Our next speaker would be Dr. Jyotirmay Paul, MD